Greetings and welcome. We are delighted to have you join us as part of a compelling and very timely discussion from UHC 2030 to sustain HIV services, how strengthened primary healthcare systems can get us there. My name is Dr. Kimberly Green, and I'm the Global Director for Primary Healthcare at PATH, and I'll be moderating today's webinar, which is co-organized by our stellar partners, WHO, GMP+, and Friends of the Global Fight. So with global commitments to universal health coverage by 2030 and to primary health care as the approach to achieving sustainable health for all, and at the same time as the fiscal space for global health is shifting and also constricting, this webinar will consider how HIV services are or are not being included as part of momentum across Africa, Asia, and elsewhere, where countries are creating strong one health, one budget, one M&E plans, and where there are essential opportunities really right now to ensure that HIV services remain available, accessible, and delivered with quality as part of integrative approaches within these health system reforms. So before I get started, I want to share a few housekeeping items. Next slide, please. As you join the call, please introduce yourself in the chat box. Also note this meeting is being recorded and we'll share the recording and materials after the call. We also very much welcome questions at any time, so please submit your questions through the Q&A box, and we will also have a Q&A discussion at the end of the panel. Next slide, please. So before I start with a few framing slides, I want to provide an overview of our agenda today. So we'll turn first to Andy Seale, who's the advisor for strategy, policy, and partnerships, HIV viral hep STI department, WHO, and Dr. Yvette Kisaka, who's the lead for HIV-NCD integration, Ministry of Health, Kenya. Both of them are going to provide framing and making the case for HIV and primary healthcare integration from a global normative perspective, as well as from a country real-life pragmatic integration perspective. Next slide, please. So we'll then turn to a panel discussion. Where are we now, taking stock of current approaches, challenges to integration, and where can we go from here? So we'll hear from Dr. George Syberry, Chief Medical Officer, Office of HIV/AIDS at USAID, and Florence Riaco Anam, who's the Co-Executive Director for the Global Network of People Living with HIV, as well as Chris Collins, President and CEO of Friends of the Global Fight, and Jaime Atienza Azonca, who is the Director for Equitable Financing at UNAID. So after that, we'll have an open Q&A with the panelists, and then we'll conclude with a call to action from Florence. Next slide, please. So this webinar is really drawn or flows from a satellite session which a number of organizations put together for AIDS 2024, and really with the purpose of looking at case studies across 4 countries who are in very different places related to integration of HIV within primary healthcare bidirectionally. And those included Brazil, Kenya, Ukraine, and Vietnam, as well as a dynamic panel discussion. And some of the panelists are wonderfully with us today, and then a call to action as well, which we'll also conclude with. And so for the session at AIDS 2024, there's a recording. So if you're interested, particularly in the case studies and really interesting discussion and questions, suggest giving a listen to the recording. Next slide, please. So as we think about the premise for this webinar and the discussion related to integration, sustainability, and HIV, for us, it's really based on this premise of inclusive universal health coverage and primary health care reforms. So we know that universal health coverage is meant to ensure that all people have access to the health services they need when and where they need them without financial hardship, and that primary health care is the vehicle for achieving that through the most effective, equitable, and efficient approach to health system strengthening. However, at the same time, issues that relate to historical siloing of HIV funding, issues related to criminalization for some populations who are living with and affected by HIV, as well as stigma, and also the importance of choice and service preferences, which vary across different populations, can all influence how HIV services are mainstreamed as part of health reforms. and create potential risks in ongoing access and quality as donor funds reduce, and also as domestic funds are rightly growing. So next slide, please. So as we think about this concept of integration and what integrated people-centered primary healthcare can achieve, effectively, I think we know very clearly that just because health services are on offer, it doesn't necessarily mean that they'll be accessible. And as we think about integrating services and systems at the point of care in a way that is acceptable to a range of populations in an evidence-based way, number of studies have shown that integration that's embedded in person-centeredness and takes into account resources and other factors improves access, improves overall uptake of healthcare services, health outcomes, and also efficiencies. And I say with caveats because it really depends, of course, on how integration happens at the service or system level. And next slide, please. And so as we consider integration, we know that there are many broad concepts and different definitions, different conceptual models and endpoints. But what's really important is that each country will choose their own definitions, their own pathway towards integration. And also that many of these models really focus on three priority outcomes: improved care, improved use of services, and optimized resources. And next slide. So even within the concept of integration, there's many different words that are used, like linkage, collaboration, alignment, networks. And so getting to that clarity in what we really mean by integration in different settings is so important. And as part of that, there's also different typologies to consider: policy integration, systems integration, so the degree to which health systems building blocks across health areas are harmonized, and all the way through to organizational, functional, clinical, and service integration. For this webinar today, we'll be focusing mostly on systems and service integration. And next slide. And so as part of the satellite session at the AIDS conference, we focused on these 4 countries. And what's really interesting is the learning in the way in which each country is approaching integration, which is different. And it's so really illuminating on different pathways that different countries are approaching. From Brazil, has a very mature primary healthcare program, the SUS, with HIV, STI, viral hepatitis, and many other services as part of the SUS, which has demonstrated person-centeredness and openness and real inclusivity of key populations and others. To Ukraine, with their healthcare reforms right now and the complexity of war, integrating HIV as part of their primary healthcare system, which is just getting started. To Kenya, and we'll hear from Dr. Yvette in just a moment, where exciting reforms with UHC primary healthcare, national health insurance, albeit with complexity, really where there's a lot of pragmatic piloting and exploration of different ways in which integration can happen, including one-to-one integration like HIV and NCDs. And then to Vietnam, where key population-led clinics that are offering HIV services very rapidly added on other services to meet the combined needs of the populations that they serve: gay men, transgender women, and other populations. And so really providing another pathway that's very important in terms of sustained access to HIV services. Next slide. So with that, I would like to turn to Andy Seale, who's going to present on making the case. So over to you, Andy.
Thank you so much, Kim. Good afternoon, good morning, everybody. Really good to be with you today. If you could move to the next slide. What I'd like to do is really just build a little bit on Kim's introduction and say a little bit more about 2 particular documents that have come out of WHO. One was a politically negotiated document, the Global Health Sector Strategies for HIV, Viral Hepatitis, and Sexually Transmitted Infections. They were approved by the World Health Assembly in 2022 and direct our work until 2030. And also, I'll talk to a framework that we developed with UNICEF around PHC, the operational framework for primary healthcare, and how we built on that on the HIV side to identify areas of convergence. Next slide, thank you. So the first starting point, again, going back to some of the typologies, concepts, and terminology that Kim was talking about, we really do start with this idea of people and person-centered care rather than disease-oriented or facility-centered ways of thinking and organizing and building our planning from. And again, I've just put onto the screen here a WHO definition around integrated health services and reference those two critical documents around the framework on integrated people-centered services and also the operational framework for primary healthcare, the WHO UNICEF document. And the next slide takes us to say a little bit more about how we've incorporated these into global health sector strategies. So next slide, please. So the global health sector strategies agreed in 2022 really took HIV, viral hepatitis, and STIs, which share a number of commonalities in terms of modes of transmission, some overlapping population groups, overlapping service delivery opportunities, etc. And we've combined them into one document. Previously, these were linked strategies in the previous strategy period that had a lot of kind of like shared content, but we've deliberately evolved the approach. So we have 4 key sections to the strategies. One section on common approaches, which really unpacks what we mean by the systems integration opportunities and service delivery opportunities, as well as some of the issues around the policy environment, etc. And then we have disease-specific chapters or sections as well. And this has really served us well. And we had our first progress report this year, and we presented that actually at the Munich conference as well. But when we're really looking through the strategies at the integration entry points, again, we're talking about common modes of transmission. So it's a prevention approach. It's looking at service delivery around comorbidities. There are certain disease interactions as well, particularly around mental health, often with a link to stigma and discrimination. And then we've already talked about common populations, particularly marginalized populations, key populations, where we need a special effort to make sure that any shifts in how we're delivering and providing services do meet population needs. Common service delivery platforms and common health system resources. And then we've also got common approaches to addressing equitable access to commodities and key countermeasures or commodities for health service delivery. Next slide, please. This is just a slide that highlights some of the key integrated areas that are highlighted in the report that we launched this year. So again, building on what Kim was saying, this is not about one size fits all. Each country really, assesses its own context. It looks at the evidence. It looks at the frameworks and opportunities that will help it take its evolution around this area of work and apply them appropriately. And lots of great learning in very, very different contexts. 2 areas that we've highlighted in the report are around integrated data systems. We think there's a lot more that can be done around the data systems that support our work, particularly around things like surveillance and how we're bringing in innovation, how we're thinking about AI and digital adaptation, etc. And then monitoring access to commodities. And again, I think my colleague from Milesi is on this call. She leads our hepatitis work, and fantastic work this year as well around really understanding what are the pricing gaps around viral hepatitis. And so, this year, again, by combining our 3 disease areas, traditionally it's been HIV really offering a bit of a guiding light to other areas, but it's certainly not the case. We've learned a lot from hepatitis this year in how they've really analysed new data and really got into details around pricing disparities. Again, we're also focused with other colleagues who are on this call on supporting countries around developing sustainability plans. We're really looking at key populations, I think, comes out as critical, and linked to that is our issues around human rights and stigma and discrimination. Next slide, please. So I talked about the PHC operational framework, and I'll say a little bit more about that just now, but just to highlight that we were really pleased to see a number of presentations in Munich this year referencing this document where we identified conversion actions. We launched it the year before, actually, and of course, as we were launching it, we didn't really get a sense of how people might receive it, but it was fantastic to see this document being frequently referenced. And again, what we've done here is we've just unpacked the opportunities across systems and services in a fairly systematic way. Next slide, please. So this is the operational framework, which is the basis for that convergence document I've just talked to. And many of you will be very familiar with this. So obviously, you know, the operational framework identifies 4 strategic levers. So it's governance, political commitment, engagement of communities, etc. And then the operational levers, which are quite similar to the health systems building blocks. So it's looking at healthcare workforce, physical infrastructure, digital technologies for health, etc. And it's a really helpful way of really understanding how can we really optimize connecting the dots, because very often countries might really excel in one area, but there's always kind of an amplification opportunity if several areas are worked on at the same time, and there's a deliberate effort to cross-reference efforts here. Next slide, please. So again, finally, just in the report that we released this year, we've also identified a number of examples where, obviously from WHO side, we've primarily started with HIV, viral hepatitis and STIs as a bit of a base for our strategies. But clearly there are much broader opportunities beyond this grouping of disease areas. But the ones that I think are interesting are on the screen here. Again, looking at integrated HIV PrEP services in Brazil, how that's really strongly integrated around STI and sexual health delivery, and really building on strong HIV platforms for integrated strategic planning processes in the Africa region, looking at key populations as a starting point for microelimination around hepatitis C in Pakistan, etc. So really great examples of how we're trying to apply some of the theory and learn from the opportunities to really assess how can we do this people-centered thing, how can we make sure that we're anticipating some of the challenges that might be faced as we evolve and encourage greater integration and a clearer focus on primary healthcare moving forward. So I think I'll stop there and hand back to Kim. Thank you very much.
Thanks so much, Andy. A really fantastic framing of the global normative guidance and that convergence document in primary healthcare. If you've not seen it, please do. There's an amazing theory of change, which Andy was behind, which really helps to unpack what is meant by HIV and primary healthcare integration. Now I'd like to turn to Dr. Yvette Kisaka, who's going to present on HIV and NCD integration as part of UHC and primary healthcare in Kenya. Over to you.
Thank you so much, Kim. I'm happy and honored to be sharing our experience with integrating HIV and NCDs as part of UHC primary healthcare. Next slide, please. So on the onset, I have to mention Kenya has a very strong commitment towards attaining UHC. And this is based on the government's specific agenda. We are calling the bottom-up economic transformative agenda, where we are focusing on providing quality healthcare that is person-centered and specifically responsive to the population's needs. A key focus, again, is strengthening of primary healthcare, where we have been able to set up community health units and primary care networks to support the attainment of UHC. NCDs have been prioritized in this agenda, number one, because they are contributing to a large proportion of mortalities, but also because we are seeing a rising prevalence or burden of NCDs among chronic communicable conditions, a case in point, and for the purpose of this discussion, HIV. So traditionally, we have seen the HIV and NCD programming have been siloed. You can move to the next slide, where we are having different funding systems, you have different programs, and again, the service points are different. But there is a general call and a push for a collaborative approach for us to be able to gain efficiency needs and also efficiency gains and also promote health equity. Because basically we are looking at the same patient within the same healthcare system, and the rising prevalence of NCD among HIV attributed to the increased longevity, but also the drugs and exposure to risk factors. Next slide. So for us, what we have been able to do with the integration approach, we have integrated both at the systems and service level. At systems, we have made sure to integrate NCD and HIV elements into program-specific action plans, strategies, and policies and guidelines, and also set up a multi-sectoral technical working group with the presence or participation of both the HIV and NCD experts. In addition, for the services, we have integrated mainly focusing on hypertension and diabetes, cervical and breast cancer, the direction mainly integrating the NCDs into the HIV care centers. The reason, because we really wanted to leverage on the existing investments in the HIV space. So what we do with the integration at the promotion level, we have integrated health messaging that addresses the common risk factors, but we're also promoting early screening and intervention. So we have screening for hypertension, diabetes, both at within the HIV clinics and outpatient general clinics. But of emphasis is what is happening at the community level, where we have been able to train and kit more than 100,000 community health promoters who are able to screen for blood pressure and blood sugar and refer as appropriate. So integration of care when it comes to the care delivery is mainly done at the HIV clinics, as I had mentioned. And to support care, we have been able to develop integrated electronic medical record systems, integrated job aids, integrated healthcare worker training to capacity build healthcare workers to be able to offer a comprehensive integrated care for both HIV and NCDs. Beyond what happens at the facility, we are utilizing the integrated HIV and NCD, PSD models and patient support groups to support with patient follow-up beyond what happens at the facility. Next slide, please. So what we have been able to see is that we are able to identify and detect conditions early and intervene early. We have been able to gain the efficiency gains, but of importance is that we have seen very good patient outcomes. A case in point is with blood pressure control. The national estimates are about 3%, but from the pilot sites where we have been able to integrate NCD into HIV, control levels are as high as 28%. Still low, we have not hit our target control levels, but we are seeing improvements towards that direction. Additionally, we have been able to encourage innovation, setting up and developing of integrated protocols and electronic medical record systems. Next slide. So what is next for Kenya? So number one is the intention to scale up NCD and HIV integration primary healthcare level beyond the pilot sites. We do recognize we have a very convenient, also supportive policy environment with the existing policies, but there's also a very good political backup, including the new policy reforms that are happening in the health insurance, health financing system. So us, we would really like to scale up beyond the pilot site and intentionally broaden the range of integrated NCD services beyond hypertension and diabetes and cervical and breast cancer. Our vision is to have a chronic care model, but in a stepwise manner so as not to lose the gains that we've already achieved with HIV. We do recognize this is not possible if we do not have very good stakeholder engagement. And so we recently had a HIV integration service delivery summit that brought all stakeholders on board to be able to support the integration agenda. Of importance, I have to mention that we are putting in the lived-in experience, the people who are living with these conditions at the center of this intervention. So they are part of this stakeholder engagement that we are speaking about. This will not be possible if you do not align systems. So we are hoping to be able to align the funding streams, align policies, guidelines, and also capacity build and make sure we have adequate healthcare workforce to support the integration. We do recognize there are challenges with the NCD space when it comes to supplies and availability of NCD commodities. And for us to have a seamless integration, we do recognize that we need to strengthen the NCD supply chain and data systems to be able to support a seamless integration. So in a nutshell, next slide, I have to mention for Kenya, it has not only been rosy. We are happy that we've taken the first step towards the journey of 1,000 miles and taking it from the Luo advice, Nyatini, Chaka Chaka. For us, we are happy that we've just started as advice. So we are hoping that we can continue walking this journey and get better outcomes out of it. Thank you, and back to you, Kim.
Thanks so much, Yvette, and really appreciate a very kind of clear, detailed description of how you've considered integration between HIV and NCDs, particularly given the health system's complexities related to treatment and supply chain overall. And this is really helpful to ground us in what's to come next, which is our panel discussion. So if we can go to the next slide, I'd like to ask all of our panelists to turn on their video. And we are going to dive into our first question, really focusing on where are we now and where can we go from here related to primary healthcare and HIV integration. So I want to start first with you, George. USAID, through its many decades of investment in community health and primary healthcare approaches, it's really, anchored primary healthcare as a core strategy to advance person-centered care. So can you tell us more about USAID's perspectives on where you are now in terms of delivering on HIV and primary healthcare integration in any or any direction, and where you hope we are in terms of delivering on integration in the next 3 to 5 years? Over to you.
Well, thank you so much, Kim, for including me on this panel. It's great to be here with so many colleagues and friends. And to talk about something that's such an important topic as countries have been reconfirming their commitments to UHC with PHC really as the cornerstone to achieve SDG goals. Primary healthcare can provide 90% of health services a personal need throughout their life, and it's an important foundation for USAID's global health investments. It advances USAID's mission to reduce inequities in life expectancy by increasing access to essential health services and bolstering national security against infectious disease threats. USAID launched Primary Impact in 2022 to accelerate progress in health and survival globally through primary healthcare. So at USAID, this commitment to PHC has us really thinking about how we collectively can advance integration and patient-centered care for HIV through PHC, and how HIV integration with PHC can advance the efforts to accelerate and sustain HIV progress in alignment with country health systems. So there are some important reasons why the time is right now for a PHC approach to the HIV response. First, the way we treat and prevent HIV has changed dramatically over the past 20 years. Testing, prevention, and treatment services for HIV are now broadly scaled, substantially simplified, and much less burdensome to clients and to providers. In short, HIV services can now be largely managed at the PHC and community level, exactly where they'll be most accessible and convenient for the people who need them. Second, when we look at the current PEPFAR program footprint, we see a substantial amount of PEPFAR-supported facilities are at the PHC level of country health systems and are linked to community-based services. So delivery of HIV services through PHC and community platforms is not new, but it needs to be expanded and strengthened. Finally, countries have made incredible progress in scaling treatment for PL-HIV and reducing new HIV infections, but critical gaps remain. And what has gotten us this far is not the same as what we need to get to our goals for HIV for 2030 and beyond. We need a different approach, and delivering HIV services through PHC and through a stronger health system will play a major role and be a big part of that different approach. As we move this agenda forward, we see many advantages to a model that embeds HIV services in a PHC context. Embedding HIV services allows programs to focus on a person rather than on a disease. People in need of HIV services routinely have other health needs, NCDs, as we heard from Kenya, mental health, family planning, cervical cancer screening, hepatitis treatment, vaccines, just to name a few. Integrated health services are more comprehensive, more accessible, and more convenient for the people who need them, and compared to parallel or segregated HIV service delivery, make more efficient use of the health system staff and other resources to deliver them. Integration of HIV services into other routine healthcare can further reduce stigma and discrimination, which contribute to the persistent gaps. And I think we can expand the reach of HIV testing and prevention services through PHC channels, which can help us reach the people who haven't been reached by our current approach to programming. In fact, it'll allow us reframe the conversation about these gaps. Instead of blaming people for being hard to reach, we can make HIV and other health services less hard to access. Finally, I'll just make a comment about young people who are really important to me and important to getting the HIV response and health response right. Instead of building unsustainable HIV-focused healthcare platforms for youth, I think we can work on expanding youth-friendly comprehensive care throughout the health system in partnership with schools and, importantly, with youth voices at the center. HIV is probably not what most youth care about and what bring them in for services, but there is strong demand for other services. And if done well, this can really be the critical platform for key HIV interventions for instance, like long-acting injectable PrEP. There are some important considerations and caveats. Country governments with civil society donors and other stakeholders need to take stock of the current health system status and really undertake difficult context-specific planning and figuring out financing for achieving sustaining HIV, UHC, and PHC objectives. Second, integration into PHC of HIV services shouldn't be limited to services delivered and run by government. This should include non-government organizations and the private sector. This is especially important when thinking about HIV and other services for KPs. We need to put equal emphasis on integration of many current parallel HIV systems, not just the services, and make sure that those are also integrated and aligned. USA is all about supporting PHC as part of its primary health development goals. PEPFAR, of course, is focused on driving HIV outcomes and is not primarily focused on PHC. But at this stage in the HIV response, PEPFAR's laser focus on achieving HIV goals may be best served by promoting delivery of HIV services through a person-centered PHC context. PHC is not PEPFAR's primary goal, but I think PHC can be the means for PEPFAR to achieve its HIV goals for 2030 and beyond. Thanks again, Kim. I'll turn it back over to you.
Thanks, George. Really brilliantly stated. I think you covered many of the really interesting and exciting elements that integration, smart, tailored, thoughtful integration can offer in terms of increasing overall sustainability, but really importantly, person-centered care that goes beyond HIV and really considers life course healthcare needs for many different populations. And I think, related to that is really then considering, what are those different needs of people living with HIV, people who are affected by HIV in different settings and at different ages, of course. And so, Florence, I'd love to turn to you and really thinking about, based on what George has said, and really thinking about countries that are looking at mainstreaming HIV into primary healthcare as part of UHC, what do you think is possible? And what do you think policymakers need to keep front and center to enable access to high quality, respectful, inclusive HIV and other healthcare overall for HIV affected populations and those living with HIV, particularly given persistent stigma and criminalization in some settings? Over to you. Thanks.
Excited and honored to join you all. I hope you can hear me okay. I would like to start this conversation from my end by indicating that this discussion for me as a person living with HIV, and I think in reality for many of my peers across the world, it means change. And change is difficult. We have been used to a particular way and shape and how we access healthcare and our interpretation of how that has been happening. And we've sort of found a way, for those of us who've been in the facility for like 10 years or 15 or 20, made it a way of our lives. And now we are in a transformative point of change. And I think as leaders, one of the things that I would like to highlight is there needs to be some careful and intention around understanding that this is not just change to systems, it's change to people and change to people's way of life. And there's a lot of need to have some very open, consultative process involving people to understand the various needs. Also, people are not homogeneous, and this conversation around integration, as I have engaged with it, even with communities, means different things for different people. There are fears, there are misunderstandings, and there's a lot that we will need to do for community to actually understand the benefits as many of us see it, because we are interacting with you more than many of us are not. And so for me, that is where I would start this from. I think my intention here, the intention of integrating HIV into primary health care is welcome from my end, because firstly, I see it as an acknowledgement of the reality of who a person living with HIV is. Dr. Yvette and Dr. Seale have just talked about the fact that a person living with HIV is beyond services. And I think Andy also talked about the policy being about people and people-centered care. And so the people or the person living with HIV is not the person that was in the 80s and the 90s. And the people entering into HIV care are at different levels. Those born with it are probably wanting to start families with it. Those who are diagnosed 30, 40 years ago are aging with HIV. And so this, in my view, is a way to acknowledge that people living with HIV have also evolved, and systems that manage and care for us require to evolve. But I also think it embodies the realities of UHC for people living with HIV, because the burdens of healthcare will be different. I look at this as a possibility of building resilient health systems that can withstand shocks from emerging and existing epidemics, or addressing many of our needs for morbidity, co-infections, and other needs like sexual reproductive health. I mean, Dr. Saibury had a whole list, that list. But I think three things that I would add for consideration moving forward. It shouldn't come at a cost to quality of care and services that people living with HIV have had and continue to aspire to have. I have recently gotten into the age where in the Kenyan system, I am needing specialist care. And I sort of realized now that I go into the broader public health system, how spoiled, if I may use that word, the HIV service area is. And I think there's a lot to learn from that, how inclusive service delivery happens, how non-stigmatizing service delivery happens, how putting people at the center and respecting people who come into care, not only just as patients who are passive, but equal participants in their whole healthcare. There's a lot that the HIV field could bring into the broader healthcare systems that could happen. So the quality aspect, the lessons that could be learned, but also the central role of community leadership and engagement in the work within the healthcare. I think the second thing that I wanted to talk about is, we know from evidence that stigma and discrimination remains a huge barrier. There is added evidence around stigma in healthcare settings, and I know there is intention. WHO released at the conference a briefing paper for addressing stigma and discrimination in healthcare settings. So hoping that these considerations are thought about more broadly within the healthcare system, because I think healthcare systems deal with vulnerable people beyond HIV. The vulnerabilities are heightened by ill health. And then I think the final one for me would be transparency between and in countries with donors and policymakers are key to making realistic decisions. Speakers before me have talked about country ownership, country realities, country data, but the decisions that countries make will be influenced primarily by what the donors are saying and the limitations of the donors and the flexibilities of the funding environment. And so all of these realities will need to come into play. But speaking as a community person here, when I'm using a Kenyan or maybe an African proverb, when two bulls fight, it's the grass that gets hurt. So we don't know the politics. We just need to know that services are assured in the quality and disrupted realities that we would need to ensure that we don't lose the game. But for sustainability ambitions and for effective integrated services, I think this transparency and honest conversations that allow for country ownership and country realities to manifest here would be critical. Now we'll stop there for now. Thanks you, and back to you, Dr. Kim.
Thanks, Florence. Thanks for multiple critical points. And one of them foremost being that, governments and anyone else who's involved in consideration related to integration of HIV into primary healthcare, whether it's public or private or wherever, that communities affected by living with HIV are directly a part of the shaping of decisions and design and implementation of those approaches. And also there's really important points around the learning that health systems can draw from HIV related to real person-centered care, quality of service delivery, how to mitigate stigma across an entire, a hospital, across the healthcare system overall, all the touch points that individuals have. And I think that's going to be a really important takeaway for us and anyone who works in HIV to really consider how that can be done. It's something that is part of primary healthcare, and yet we know it's still a struggle. And it's part of why Health for All is a challenge in a number of settings. So I think that's a really critical call out. I want to turn now to you, Chris. So just really thinking about integration and the work that you've done as a long-standing champion of the role of the Global Fund and the importance of the mission of the Global Fund and ensuring year-on-year investments. You know, I think you've also done a lot of really interesting thinking about person-centered care in HIV and how that could be influenced, could influence primary healthcare overall. And also have done some thinking just in general around how the HIV platform could involve other healthcare areas, right? And so I'm really curious to how far you think the Global Fund can and should go in partnering with countries to advance the integration agenda through their One Health Plan, One Budget, One M&E, as part of Global Fund's mandate moving forward. Over to you.
Thank you, Kim, and everybody. This is an amazing panel. Yeah, a couple things. I think first to say that the Global Fund is, like all organizations, is in the midst of changing and understanding what role they can play in integration. In a lot of ways, the Global Fund is uniquely positioned to be at the forefront of integration of services because of their considerable health systems investments in multiple areas, but along with the fact that they tackle human rights and gender barriers and services for key populations and for the most vulnerable. So Global Fund really can be a critical pathway to UHC and to integration. In addition, the investment in community systems by the Global Fund and the fact that, as we've been hearing, community really can be the bridge between disease-focused programs and broader healthcare. Those things make the Global Fund a good place to think about integration. The Global Fund came out with a guidance note in February of 2023, and it dealt with the fact that people living with HIV are living longer, and so they have develop a whole variety of health needs as they age, of course. And so the guidance note that came out really called for partners to develop programs that were that had integrated person-centered care that holistically addressed the needs of people living with HIV all along their life course. And that included, they're looking for systems integration in areas such as testing capacity, health information, differentiated service delivery across diseases, multi-month dispensing for multiple diseases. So they've identified all these ways and more that integration can happen. And this guidance note is kind of still the latest piece, official guidance from the Global Fund that speaks to integration, but I really think it opens the door to a whole lot of things that partners can do with Global Fund resources. A couple of examples. Rwanda identified that it had a big Hep C epidemic and worked with the Global Fund to procure hepatitis C rapid tests and viral load diagnostics, along with antivirals for people co-infected with HIV and Hep C. In sub-Saharan Africa, 12 countries are part of the Go Further campaign to integrate cervical cancer prevention in HIV care settings through screening, diagnosis, and treatment. So those are a couple examples that the Global Fund itself has cited. I will say I did a whole lot of interviews during the height of the COVID pandemic about the role of the HIV platform in helping countries respond to COVID. We did see the HIV personnel involved in HIV, communities, community systems, researchers, laboratories, supply chain, you name it, was able to pivot and really help countries respond to this new disease threat of COVID. And I got the sense from those interviews too that the Global Fund the Secretariat is really open to looking at integrated opportunities even more broadly that's in the concept note. So I think that's a good thing to know, and I think that's a developing area for the Global Fund. I would say that, and others have mentioned this, there is potentially a tension here because the Global Fund was created to end the epidemics of AIDS, TB, and malaria, very results-oriented in those disease areas. I hope none of us want to lose that ambition and lose that goal, but rather I think what we're saying is we need to carefully look at how can integration actually advance those goals of ending those epidemics. It is just as true also to say that you can't end the epidemics of AIDS, TB, and malaria without integration. In fact, I was recently at a meeting where Tom Frieden, who used to run the US CDC and now is at Resolve to Save Lives, said the sustainability agenda for HIV is primary healthcare. That's the only way you get to sustainability. Kim and others noted that PATH, JSI, and Friends did a report on integrated person-centered care and health services, translating lessons from the HIV response. That's a good source. And, you know, it talks about how integration is essential, but it has a few points. No one size fits all. Really, how you do integration needs to be site-specific. We need to monitor outcomes in a variety of areas, including in HIV, to make sure we're not slipping in terms of the quality of HIV-related services. That integration looks different for, you know, where you sit is where you stand. For many people, they really want that integration to be happening in a public health system. For others, perhaps marginalized groups, they're going to still need dedicated services, which you can build out from to provide broader services too. So integration can happen both in a lot of different ways, from HIV into primary healthcare, and then bringing in primary healthcare services into an HIV platform. And that we don't need to, we must not lose the strengths of disease-focused programs like the commitment to access for all, results orientation, and a focus on the most vulnerable. We also did a report with UNAIDS. There's a new report actually from UNAIDS and PEPFAR called Equity in the HIV Response, and it is really an excellent report. I hope everybody looks at it, because I was not involved in it, so I can say that. But it's just a really great review of the research, and it finds that, it makes several important points. One is that the HIV response in general has a, quote, clear equity advantage, that we've built in equity into the way we provided HIV services, and we must not lose that as we think about integration. It warns that wholesale absorption of HIV programs into broader health systems could result in the loss of many equity gains of the HIV response if we're not careful, and if we don't attend to the fact that, in environments where there is homophobia and gender discrimination and inequality and the presence of other kinds of discrimination, that integration that's not done carefully could take us backwards on equity. I would also note that Wafa El-Sadr of Colombia has a presentation with a great quote in it, and it's on integration in HIV. And she wrote that integration is not the end goal, rather the means to an end, which is achieving and sustaining high quality, acceptable services for recipients of care. So I thought that was a really good guidepost. And I just also want to note a great article in The Lancet from last year from Deborah Goldstein and colleagues, a really great source on integrating primary healthcare and HIV services. Finally, I just want to say we did a report with Elton John AIDS Foundation and UNAIDS on expanding on how this can work the other way, that in some cases you can, from the HIV platform, expand out and add more services. So you reach broader populations with broader services. So integration can work into the healthcare system. It can broaden out from HIV. There's a lot of possibilities here. And now, finally, in closing, I want to quote Florence from July when we had this session, because Florence, I think you nailed it in what you said today, but also in July. You said in your presentation, sustainability is good, but it needs to be done in a progressive way so that we do not lose the gains and the strengths and the benefits of investment of the vertical programs. And it can only be successful if we have efficiency and equity. And I would like to add, as I'm a person living with HIV, we do not lose quality. Thank you, Florence.
Beautifully said. Thank you, Chris. Thank you for all of the thinking related to the Global Fund and the change that is underway, and where many global health investors can and should be headed related to supporting countries in their own integrated One Health agendas. But also for really thinking about many different thought leaders considering a titrated, thoughtful, and careful way to approach integration, including Florence. So with that, we need to turn to the money, the financing questions as part of sustainability. And so we're very fortunate to have you with us, Jaime. UNAIDS has launched guidance, is supporting countries with thinking through sustainability roadmaps. And it'd be really helpful to hear from you, as you're observing countries that are moving through this process, where do you see the potential for financial efficiencies with integrative approaches or not? It'd be really helpful to hear your reflections on what you see thus far. Thank you.
Thank you very much, Kimberly and colleagues. It's a real pleasure to be with you, with most of you again. You have in the room I think some of the thought leaders of how to take a smart pathway into the future that definitely includes integration but goes way beyond. Let me get to the financing, but let me try to summarize 5 points for the audience today. I think as I was listening to others, I've been doing my own notes, because I think really one of the important things to bear in mind is that sustainability of HIV services, or sustaining the HIV services in integration in an integrated primary healthcare system, is part, but not all, that needs to be done if we want to sustain the HIV response. That's a more complex endeavor, has multiple dimensions. We talk about the political, the services, the policies, and the financing. So I think that's something important to mention, and sustaining the services, but also the quality, the equality of those services, and the inclusiveness is critically important. And I think we have the challenge from a financing perspective of doing this, of seeing this integration pathway that we are talking about in a context where, just to give you the numbers, in low and middle income countries, the financing, the domestic financing for health in low and middle income countries is 96% of the budgets of low and middle income countries. The HIV financing of those same low and middle income countries, the domestic piece, is not 96%, is 34%. So we see a real big mismatch. We see that HIV is financed mostly internationally. Health as a system is financed mostly nationally. In low and middle income countries, I will not go to the extremes or to low income countries only. And that tells us a story that's important as we move forward. We need to build the future of the HIV response within, or integrated, or embedded, as Chris was saying. In what direction we cannot say, but on the back of systems that are strongly underfunded and in many cases very weak. So that's the reality. We would like to think, maybe because we are taking this long-term approach in UNAIDS, we want to think in 20 years' time, there will be a solid health system that will be able to embed with all the other multiple sectors a solid HIV response. But that's not the material reality we are in today. It needs to be built. It needs to be developed. So I think that was my first point. I think, of course, we need to sustain the response, but we also need to transform it, and that's something that we've been insisting and hammering with. And I think some of the previous speakers have said that very well. It's not, we don't need the same for the past that we need for the future. We will not need the same depending on what the epidemic trajectory in each country is. We will not need the same depending on what the enabling environment is and what the policies are, what the human rights environment, what the degree of stigma and discrimination are. So transforming the response, adapting it, is going to be really, really important. That's my second point. I think the third point is precisely on that enabling environment and structural drivers of a successful HIV response. We need to keep those in mind as we look at a sustained future. We are looking here at the services, and I can say this because all my colleagues have done a great job of talking primary healthcare and how it integrates, and we have seen the examples, and we learned a lot already in the summer in our session on how this needs to happen. But again, keeping high human human rights and the fight against stigma and discrimination. So enabling policies, enabling laws, the education elements, secondary education for adolescent girls and young women as a key element to keep them protected or to keep them less in risk, and above all, community systems as part of the response. All these elements are both service, some are services, some are enabling, some are combined. Communities tick on both, but we need to make sure that when we look at primary healthcare and integration, we are looking at those. My fourth point is landing on integration and efficiencies. And my answer in short is yes, absolutely. There are important financial efficiency gains to be achieved through a successful, well-charted, well-planned primary healthcare and HIV integration. Not only primary healthcare and HIV, there are also other dimensions, but definitely the response, I think, is yes. Of course, more and better results for larger groups of population while securing more results for HIV, and something that has been mentioned by my predecessors, all the support that beyond the HIV, people living with HIV do need and will increasingly need as a result of an aging population. Of course, integration also affects other dimensions. We are talking financing. So when looking at financing instruments, we need to make sure that as these are designed, not only that we have sufficient money, that the resources are affordable, but that when new packages in the health system are designed, all the pieces that have to serve the HIV response and people living with HIV are included. When many countries are taking the pathway that will be successful in one cases, but also can have flaws of health insurance mechanisms. Well, those health insurance mechanisms will need to include all that is related to testing, prevention, treatment of HIV, and we are seeing cases where that is not the case. So that's a red alert, I think, a red flag we need to raise. So those efficiencies to be gained are definitely there. That's especially necessary now. Yes, we need to go for them. Absolutely. There are some things to be kept in mind to avoid these, to avoid some backlashes. And finally, social contracting and community systems need to be absolutely part of this. My final point maybe will touch on things that Florence, Chris, George, Dr. Yvette, and Andy have mentioned, and are some of the risks that we may face. And the risks are not to say, oh, we don't need to do this, but rather we need to plan well on how things go. And that has to do with the access, with the quality of service and the quality of care. So with that people-centered elements that were mentioned, with the inclusion of HIV in financial packages, but also in the services, and finally on the financial availability. We know that we are in a declining pattern from international donors, but that cannot happen in a short period of time. It needs to be sustained over time. It needs to be, if it comes forward, it should be a decline that is very progressive, very well planned. I agree. I concur with some of my colleagues. We need to be able to take it step by step to make sure all the steps are solid. And that will require still international financing, especially because low-income countries and low-middle-income countries are facing a fiscal crisis. Since we started with COVID, they are not coming out of it yet. And in many countries, in Africa, on average, we've seen how debt repayments are raised and are eating up the budgets for health, education, and other social priorities. We need to make sure we alleviate that weight for countries so that they can increase their domestic resources and they can invest more in health and have a good balance of international and domestic financing in the meantime. So let me stop there, Kimberly, and thanks.
Thanks so much, Jaime, and really appreciate very grounded perspective, in particular, really underscoring that this is a much longer time horizon, in that to have strong primary healthcare systems in place, overall there are shortfalls in investment, and this we know, and there's further setbacks because of COVID and many other factors. And so really, I mean, I think what belies a lot of this is a call to action for global health investors to be considering ways in which they can unite behind those primary healthcare overall plans that governments are putting forward, which we've touched on throughout the call. But really does sound like there's more of a concerted agreement or partnership across donors that may be needed in order to help governments to make those investments that are required now to set up their national health insurance systems and all of the supply chain and everything else that's required to have foundational high quality primary healthcare overall, and to then enable that integrative approach for not only treatment but also thinking about testing and prevention and more. So it truly is a long game. Also appreciated the fact that you do find that there are efficiencies with integration, with all the caveats of it being done in a thoughtful, evidence-based way. So with that, thank you all very much. It's extremely rich conversation, and I wanted to call out one thing and then ask you a question. So the first call out is that International AIDS Society, led by Emma Williams, who's on this call, I think still, has been leading a really engaging and comprehensive discussion on what is meant by person-centered care that could be distilled in the HIV space, that could be distilled in thinking overall for primary health care and UHC. So if she's still on the call, asking if she can post some of the information related to this effort, because I think it's really helpful as part of this conversation. And then a question to pose to all of you. Chris, you called out COVID and really how the investment in HIV infrastructure, lab, contact tracing, all of community-based organizations, so much more, led to some very effective, rapid approaches for the COVID response. Now, in the midst of monkeypox, it'd be really helpful to hear, with the outbreak, change in clades, complex situation across Africa, where do you see integration in terms of, utilizing investments in HIV towards addressing mpox? So whoever is interested in jumping in to answer that question, feel free.
Kim, I'm happy to start. Others should certainly add, but I think one of the premises here about the primary healthcare approach, right, is that emerging diseases and epidemics, they don't start in big hospitals. They get their start in communities. And so if you've got a primary healthcare system with good community linkages and good community-based organizations involved, that is going to be the setup that on regular days helps provide good healthcare for all, but that is also poised to detect when problems arise and then reach people with messages and services, and then referrals as needed, of course, right, to higher level care. But it underpins again the multiple benefits to populations and health systems of a primary healthcare approach with strong community linkages that will serve HIV routine health needs and be really poised to detect and respond to those emerging health threats.
Yeah, thanks so much, George. Yeah, Chris, go ahead.
Yeah, I just would point out that the monkeypox example, both the former epidemic of that and the current one, is just, we're kind of being beat over the head, but we're not listening. I mean, it's one more example of how we should be investing ultimately in health systems to help people. That the current emergence of monkeypox would have been, more people would have been diagnosed and gotten the treatment they need if we'd had comprehensive systems of care for people. And so, that's the ultimate answer and the ultimate lesson, I think, that these continued outbreaks are telling us is that's what we need to be working together to build. I will say for the Global Fund on monkeypox, it has allowed partner countries to utilize grant flexibilities to redirect money towards monkeypox. It's just approved nearly $1 million at the request of the Ugandan government for reprogramming. and it is available to do that with other countries. So it's an example of how a system can respond by having cash in hand and allowing that to be redirected very quickly without delay when a new epidemic emerges. So I'm not saying it works perfectly, but that's one example of how a system can adapt. But ultimately, I think one of the lessons of monkeypox is the need for strong health systems.
Thanks, Chris. Florence.
Yeah, I think eloquently said, but I just wanted to bring the community aspect one, but also something else. So I think first, the realities of how we experience COVID and how communities are engaging with the response to mpox are just because there have been existing strong infrastructure on communities and community systems that are built, I think, out of HIV, TB, and malaria responses that are now being used to leverage upon to, inform and educate community, talk about literacy, share information that is needed, demand creation, etc. And I think there's a component of that we can't lose, and we have seen through evidence that it helps you. But I just wanted to touch on something else. I think the HIV program, particularly in its investment in research and optimization of treatment and diagnostics, provide an opportunity. I look at it like listening to everything that is in the pipeline, multi-testing, diagnostic tools, etc. And I think these provide an opportunity not only just for the diagnostic equipment to get to broader people across different vertical programs, but also for the messaging that communities could get that, oh, I could have HIV treatment, but because now there's U equals U, there's need to have testing for STIs and screening. And so this broadens as well the opportunities for community awareness and treatment and engagement that naturally, I think, will organically not happen within the vertical, but mostly looking at the person. And so this, I think, is why sometimes communities rather ahead in its realities. Just to say that, back to you.
Absolutely, 100%. And also, I was just thinking the same thing about, multiplex testing and just really how the tools used in the community and other settings that can further enable that integrative approach. And there was a great poster presentation at the AIDS conference presented by colleagues of yours, George, Liz Manfredi, and another person, I can't remember. And it was really looking at dual testing for HIV and syphilis in ANC settings primarily, and how, although not fully, but with the dual test really found that treatment for syphilis and access to methazine penicillin G increased dramatically. And so it'd be really helpful to hear further thoughts that you might have on these integrative approaches we can use through tools and what more we can do, because dual test proof points are exciting, and there's so much more that's in the pipeline right now, including integrated therapeutics or preventative tools.
I'm so glad you highlighted that really nice, I think, presentation, right? And I think it's a good example of, if you've got a well-developed approach for reaching people, then instead of having a different one developed for each disease, which is highly inefficient and very cumbersome, right, for the recipient of care, you leverage the approach, the relationship, the access to say, well, what are the needs that need to be addressed today, right? That's the primary healthcare approach. And the dual testing, and some people are working on ways to, for instance, add in hepatitis testing as well to that, is a great example, because again, that pregnant woman, she's more than just a pregnant person. She's more than just someone in need of HIV. Also, that's the opportunity to test for syphilis, treat if it's positive, find out if she has hepatitis B, and make sure, if so, that baby has access to birth dose of hepatitis B vaccine in addition to routine prevention measures. You can leverage and synergize in ways that get, I get excited about it, right? And I think that we lose that opportunity too quickly with a narrow and siloed approach about, what we're trying to get out of an interaction or an investment. It's fine to say the investment from PEPFAR needs to be connected to an HIV outcome, but how we do that and the platform we work through can absolutely take into account opportunities to expand that benefit to what the person who is coming for care exactly needs.
That's great. I think that's a really exciting framing or way of thinking about how integrated tools can really have a multi-purpose and have much broader benefit. So, and just thinking about, syphilis, thinking about viral hepatitis, it'd be great to hear further examples around how integration is happening with key populations. That's been called out by several of the panelists and speakers, just in terms of the importance of really being very careful in how integration is happening. So would love further thoughts and specifically examples that you might have on where that's working well. And George, I can put you on the spot again.
I'm feeling bad that you're hearing my voice so much, but I'm so excited that you kind of raised that. I think I've heard people talk about concerns appropriately about integration for services for marginalized populations and populations that are the object of discrimination and really just a terrible treatment, right? Our key populations. And I'd like to help us make sure we distinguish integration into the public sector clinics from integration of the health services that those populations need. And I feel like they're very important but distinct points. And on the first, I, at this point, think in many settings, we need to preserve the ability to reach and deliver services for KPs outside of the public sector until such time as the public sector is appropriately responsive, capable, and ready to deliver care in a non-discriminatory and open way. But we should not limit then our goals for those services to just be HIV services for KPs. Again, it needs to be person-centered. You're not treating a disease, you're treating people, and people from KPs walk in also with a range of health needs. And so integrating services for KPs can happen outside the public sector and be comprehensive. And I really think, Kim, that is key. And those are the opportunities where through excellent community-based organizations that welcome KPs and make KPs feel ready to really come and seek what they need. That is, again, the platform. You already have the trust and the access to people in need of services. So you have your HIV, your syphilis, your hepatitis, your family planning, and then the other health needs. And maybe you can't deliver all of them in that community-based comprehensive KP service organization plan, but you can make sure you have allies in the public sector where higher level specialty care might be needed, referrals that are facilitated and monitored for that other care. But in the meantime, let's also maximize the services that can be delivered in the KP channels and go way beyond just thinking about HIV. But I'd love to hear Florence or maybe Chris react to that as well to see if that resonates.
So thank you so much, George. And Chris, if you don't mind to be quite brief, I'm going to turn over to Florence to help us wrap up.
Sure. No, I mean, I completely agree. We need to be thinking about both things happening. Public health systems where everybody's welcome and feels safe and is treated with respect. And we need to be working towards that, knowing that that's not going to happen tomorrow. And we, also not as a backup, but as its own strength and importance is community systems that can reach key populations, realizing the strength there, that even in a perfect primary healthcare system, you're going to want dedicated services for some populations who want services run by KP, who want services run by the community. We know one thing we learned in COVID is the incredibly important factor of trust and the ability of community systems and KP systems to engender that trust with folks who need care. So This report I talked about with UNAIDS and Elton John AIDS Foundation has 6 examples of where countries have built out from their HIV platform. So that's definitely a place to look.
Thanks, Chris. Thanks, George. Thanks to all of the panelists and the presenters. I want to turn to Florence, who's going to help us wrap up. Jaime, just flagging, there's a great question for you in the chat if you wouldn't mind responding to it. Over to you, Florence.
It's been an exciting discussion, and I hope it's not the final one. It's one of the many that will have us eloquently said from Dr. Rafa's quote, this is a means to an end and not the goal. And so I think one of the things that are coming out of this is policy is key and important, and there is some guidance and documentation and policies coming out of WHO that many countries are adapting, and I think we'll need to share with broader stakeholders for many people to understand the areas of convergence and the examples of integration opportunities across different diseases so far and different health systems. And I think there are countries that are already piloting, and there are lessons there with intentions and the political goodwill to want to take this to scale and opportunities to support countries like Kenya and others. And I think the role of political leadership and political goodwill is critical. We've learned that from HIV. We are seeing it in the pilot countries, that is primary, especially since most of this will require some aspect of domestic funding allocation to make this work. There are a lot of efficiencies to be gained out of integration, and I don't think we know realities of the full extent of it, but we have enough to know that there are efficiencies and the realities within which they are to adapt and to build resilient health systems. I think I had a lot about, we are not starting from scratch. Things are already happening that we can build up on. And there was the need to be clear on the realities of inequalities of fiscal space within countries and to be intentional around that. There is a lot of talk around centering communities, community leadership, engagement, and the importance of community health systems. And a specific ask that quality and equity gain shouldn't be lost in this journey of integration and the interest and the ambition. And I think a lot has been said and lots of opportunities for broadening services to address other comorbidities, address using tools as an entry point for integration and all of these things, but also distinguishing integration into public healthcare and integration that broadens from the HIV care and finding out what are the benefits and the cost and the benefits across all of them, but the realities around how to address marginalized population, key populations, and of course, populations on the move, different vulnerabilities that exist, so that this process does not further inequalities, but tries to really, really keep up the game and get to the realities of equity as desired. I want to thank you all. It was a very, very interesting conversation, and there's lots to learn from it. And I hope that we can continue this discussion, and let's have communities involved and engaged at every point so that we are working this journey with you. Thank you so much, and back to you, Dr. King.
Thanks so much, Florence, for the excellent summary and call to action. I want to thank our brilliant and esteemed presenters and panelists, to Andy, Yvette, George, Florence, Chris, Jaime. Huge gratitude to you for joining us and for sharing your wisdom. This is a really thoughtful and inspiring conversation. Florence, as you said, it's part of an ongoing conversation. There's so much live learning that's happening right now related to what integration can mean, which is very different in different settings and for different populations. And so I want to say, stay tuned for a follow-up conversation. We'll have huge gratitude to WHO, to GMP+, Friends of the Global Fight, and all of our partners for the satellite session at the AIDS conference. I want to wish everyone a wonderful rest of day ahead, and thank you.